Okay, well, I'm glad that's better. Okay, so and then the two medications that we haven't gone through yet that have to do with um, Parkinson's disease. So remember, Parkinson's disease is not enough dopamine, and so we're using medications to try to increase the amount of dopamine in the basal ganglia. And we talked about levodopa carbidopa, which is a synthetic dopamine, to try to bring the dopamine up. There's two other medications. Pramipexole is a dopamine receptor agonist, so it acts like dopamine in the area of the basal ganglia in the brain to try to rebalance the scale. It's a medication that's taken by mouth. It also can cause nausea and vomiting, so it should be taken with food. But again, all these medications, especially in the beginning, have those dyskinesias, just like levodopa carbidopa did. Then you can accidentally or could get some tremors, head bobbing, lip smacking, kind of disturbing, sort of annoying symptoms, but those medicines make it easier for your arms and legs and the rest of your body to move, so it's sort of a balance. And again, we have to worry about falls because Parkinson's people already have a stooped posture, and this medicine also has a risk of orthostatic hypotension, muscle weaknesses, and something called sleep attacks, in which the person has almost like a narcolepsy where they just sort of fall asleep. So that has its own issues. And then the last medication is selegiline, and this medicine is usually taken with levodopa carbidopa. And what it does is it decreases the inactivation of dopamine in the synapse by inhibiting the enzyme that breaks down dopamine. So, like we talked about with pyridostigmine, which is the myasthenia gravis medication, where we decrease the activity of cholinesterase, and donazepam, which is Alzheimer's medication that decreases the activity of cholinesterase in order to increase acetylcholine in the synapse. Instead, this is a different enzyme that we're inhibiting. It's MAOB, which monoamine oxidase. That enzyme is inactivated so that we can leave dopamine in the synapse longer. And so if we take the medication with a dopamine-like medication, and then we give it then we can make the dopamine even last longer. So the biggest issues with this medicine is that it's an oral disintegrating tablet, and it can cause irritation and ulceration to the tongue. So you have to watch the patients just sort of move around which part underneath the tongue they're dropping it into, and you have to watch for sores on the tongue. The worst thing that happens is insomnia, so you cannot give the medication before noon. So that's important. Do not give before noon or the patient won't be able to sleep. And you have to avoid tyramine foods because it could increase the risk of hypertension that's very, very high. So tyramine foods are things like chocolate, aged cheese, wine, sausage, lots of things that people like. And that has the potential to increase the patient's blood pressure. Yes, so I had to resend, which I did, the neuro slides, and that's why we took the longer break, is because those two medications got dropped off the original slides. So I had to put them back in. I don't know how that happened. It's just kind of going with the day itself, I guess. So you do have it. I did send it, but the first time we opened the slides, you did not have it. Okay, good. Excellent. All right, and then we talked about Alzheimer's medications, and so now we're moving on to our next thing. Oops, that's not what I want to open. Now we're moving on to our next thing, which is seizures. So seizures, what happens for a seizure is part of the brain, there's an area where there's too much electrical activity. And so abnormal, uncontrolled neural impulses are sent down into the body. So depending on where that is, where that little focus is, or that section of abnormal activity, depends on the kinds of symptoms or the kinds of seizures the patient will have. So a seizure is the actual nerve activity. Convulsions is what you sometimes see when the patient is having a seizure, which is the muscle spasms. There are different types of seizures, partial seizures, where it's only part of the body that might be affected, versus generalized seizures. Some seizures, it's very clear because they are paired with convulsions where you see all the muscle spasming. Some seizures, it's hard to tell if they just sort of, they're sometimes called absent seizures, where they just sort of stop moving. There's the uncontrolled nerve impulses inside their brain, but you can't see the muscle spasms. The other seizure term that I like to be sure we know is something called status epilepticus, and that means that the seizure isn't stopping. So usually someone will have kind of like a migraine, you might have an aura or something that people experience before the seizure happens, which is good because that can be a warning sign to get to safety if possible. But sometimes there'll be like a smell or a visual change or something, not always. Then the patient has the actual seizure, whichever type of seizure it is, whether it be generalized, absent or silent, a partial seizure. And then after that's over, there's a period of fatigue. The patient during the seizure could be incontinent, and then they might be difficult to awaken because they're so tired, sometimes called a post-ictal state, where the patient takes a while to wake back up after the seizure is over. Someone who has status epilepticus is not having this, they're just having a continuous seizure, and so you have to give them medication to stop it. And that would be an emergency situation. So the key to medication management is to slow electrical activity in the areas that are hyperactive. And there's traditional medication and non-traditional medication. And as I've been teaching this and the books and ATI have updated, there used to be a focus on even older medications that now we just use for status epilepticus, and very minimal mention of the non-traditional medications. And I think as time goes on, there'll be more emphasis on the non-traditional medications because they tend to be better tolerated by people. But for now, ATI focuses mostly on the traditional anti-epileptic drugs or traditional anti-seizure drugs. So the way I have this grouped is medications that you would use for status epilepticus, those continuous seizures that you would have to arrest to stop, and the same family of medications that's used for status epilepticus are also medications that are currently used as part of general anesthesia, which is how ATI talks about them too. And then the traditional medications, of which there are 3, and then the non-traditional medications are just mentioned. In your book, they talk about the non-traditional medications a little bit more, but ATI doesn't really talk about them. And so I just want to be sure that you're ready for the ATI. So that's how we've organized the seizure medications too. So the first grouping of medicines, the overall pharmacologic effect, is to change how GABA works. So GABA is a receptor located on the cell. Now remember that the whole point of these medications is to decrease electrical activity. So that means to decrease the action potential. So the major intracellular cation is potassium. The major extracellular cation is sodium. The cell is always more negative than positive. Inside the major anions are proteins and chloride. So in order to have the action potential, sodium gets into the cell to make it positive, and then we have to kick potassium out in order to start to bring the cell back to its resting potential. That's how it usually works. If we want to delay action potential, we can alter the way these electrolytes work in cells. And GABA helps open the chloride channels. And if I open a chloride channel, then I make the cell very negative. So it's much harder to depolarize that cell or to have an action potential. And the goal is, in status epilepticus, the goal is to quiet all the hyperactive areas in the brain. When we're using these medications for general anesthesia, the goal is to really bring those levels down so that we can perform, a surgery or procedure without the patient being aware. So drugs that activate GABA increase chloride in the cell, and those two families that increase the GABA use so that the cells are more negative are barbiturates and benzodiazepines. And you might notice that these types of medications can also be drugs of abuse. And benzodiazepines can also be used in lower doses for things like anxiety and sleep. So we'll talk about that this afternoon. Barbiturates act like our GABA receptor agonists, so they activate those chloride channels and open them up. The medication we use for status epilepticus is phenobarbital. The medication that's used for anesthesia is Diprivan. You might recognize Diprivan if you remember when Michael Jackson died. His pain doctor, anesthesiologist, used to give him Diprivan in order to sleep, and ended up giving him too much is what eventually killed him. It is a very good anesthetic. Phenobarbital, when given IV, can very quickly arrest seizure activity, but just like when it's used for anesthesia, we have to worry about CNS depression because it's going to turn off the area of seizure, but it's also going to decrease all CNS activity and potentially decrease heart rate, blood pressure, and especially respiration. So people who receive these medications either as anesthetic or to stop seizure activity need to be on a monitor. They need to have their respiratory rate checked often. They may end up needing to be attached to a ventilator to be intubated in order for their breathing to be controlled outside mechanically because they can't do it on their own. The other class of medications that manipulate GABA to make the cell more negative are benzodiazepines. The medication that can be used to stop seizure activity is diazepam, which is Valium. The medication often used for general anesthesia or for procedures where we're trying to do like conscious sedation is midazolam, which is Versed. Diazepam can be given POIM or IV. Midazolam is an IV medication. These are CNS depressants because we're making all nerves more negative, so it's harder to fire the action potential. With midazolam, the extra benefit for use in conscious sedation is it causes memory loss, what's called retrograde memory loss. So you forget everything that occurs at the time that the medication was given and thereafter until it wears off. So you can use it for conscious sedation, which the patient might be partially awake, but they won't remember the procedure at all, even though you're talking to them about it during the procedure because of that. But again, we have to worry about especially respiratory arrest. And for these procedures, conscious sedation procedures, or if we're giving diazepam because the patient is having status epilepticus, we have to carefully monitor their respiratory rate, their airway, and their breathing in case they need to be put on a mechanical ventilator. So we will talk about benzodiazepines again in the afternoon when we talk about medications that can be used for anxiety. And then we cover the major medications that work in order to decrease seizure activity on a daily basis, what are called antiepileptic drugs. And these are the traditional antiepileptic drugs, the first ones that were around. They are still used, sometimes in conjunction with some of the non-traditional medications. But these are the drugs that ATI emphasizes the most. And so we will emphasize them too, just to prepare you for that exam. So what these medications are doing is suppressing the influx of sodium. So we're back to that cell that has a lot of potassium inside and a lot of sodium outside, and its resting potential is negative, and depolarization occurs because sodium goes inside the cell, and depolarization means there's an action potential and the nerve has fired. So if there's an area in the brain that's hyperactive where the nerves are firing too often, if we stop the influx of sodium, then it'll be harder to depolarize that hyperactive area, and so we should be slowing down seizure activity. However, it is possible that we might slow down all electrical activity. We have that potential. Just like all the medications we've talked about, we might want to decrease the seizure activity in the brain in the hyperactive area, but we could also decrease the electrical activity in other parts of the brain or other parts of the body. So we have to be very careful when using these medications so that that doesn't occur. So these medications can be kind of dangerous. We want them to be in a certain therapeutic range. The smallest or tightest therapeutic range is with phenytoin, which is Dilantin. It needs to be within 10 to 20 micrograms per milliliter in the bloodstream. So we have to be sure that this is being monitored often. Carbamazepine, which is Tegretol, and valproic acid, which is Depakote, which are the other two traditional anti-seizure medications, also have therapeutic ranges, but their therapeutic ranges are larger. So you have to just memorize the phenytoin one, because that's the one that we are worried about the most in terms of small or range. IV phenytoin has a lot of incompatibilities, and it must be mixed with saline only. There can't be any sugar mixed with phenytoin, or it'll become sand. It'll precipitate, which could lead to an embolus or a clot formation or something. So if the patient has a capped IV and you're just giving this medication through the IV when they need it intermittently, then you would that's the time where you get that little mini bag that's mixed with the medication and you hang it at whatever rate the pharmacist said to do. And phenytoin must be given slowly in a dilute form to prevent fairly low heart rate and blood pressure. So that'll be prepared and given to you. And then obviously you would flush the IV, give the medication, and flush the IV again with saline. If the patient had continuous IV fluids, or what's sometimes called maintenance IV fluids, and those fluids were saline and didn't contain any dextrose, like maybe it was 0.9 with potassium, or just saline, or 0.45, which is half normal saline, or something like that, that's running continuously, then you could set up a piggyback, or the secondary setup where you have your maintenance IV going in and then you have a little piggyback. You could do that if the main bag had saline in it without sugar. Then you could just, that IV is running, so you don't have to flush it. It's being flushed by the continuous fluids, and then you would just give the medication. So obviously that would be our math, which we'll practice in the afternoon too, would be calculating the rate of that secondary infusion. If the patient's maintenance fluids had sugar in them, if it was D5 with some other electrolytes in it or contained dextrose, then you cannot run as a piggyback the phenytoin, or they'll mix in the fluid and that'll cause the embolus issue. So then either you have to remove this whole setup, flush, give your medication, flush, and then reconnect the dextrose, or you have to make or put in a whole new IV line. So obviously I spent a lot of time explaining that. You're going to need to know that. How are you going to manage this phenytoin depending on what the patient already has going? This medication is a vesicant.
So, say for instance, they're getting a dextrose before you come in there with the phenytoin
Yes,
medication,
mm-hmm.
And you said that we have to flush it before we can give it, but it can't be given with dextrose. Is there a specific amount of time in between, like once you stop the dextrose and you flush the IV? Do you have to wait a specific amount of time before you can give this new med with saline?
Good question. No, you disconnect it and flush it. You've already flushed that medication out of the tubing, so then you're good to go. You can just give your medicine.
Okay, thanks.
You're welcome. So, and then you have to be careful which kind of IV you use, because this is a medication that is a vesicant, meaning that if it gets into the skin, it will cause the skin to die. It can cause like what looks like a burn, could lead to, a big sore for the patient, or something that might need skin grafting. So you have to be very, very careful with this medicine. So you can give it IV when you first want to start it, or if the patient's level is too low, then you can use the IV as a way to give a high dose, or if they can't take things by mouth for a while. You could take it by mouth, and people can take that daily as a maintenance medication. It is it's a teratogenic, meaning it can cause birth defects in the infant, unborn child, so people are cautioned about getting pregnant. And the problem is it also decreases the effectiveness of oral contraceptives. So if the person is not pregnant, then they are in a relationship where we don't want to worry about them getting pregnant, then they have to pick a birth control method that isn't an oral contraceptive, because that won't work. Again, it has that narrow therapeutic range, so 10 to 20. If it's below 10, the patient will probably continue to have seizures, and so we'll know that that's not working. If it's above 20, the patient will be more confused, will have something called ataxia, which means they have difficulty walking, their balance looks off. They could be very, very sedated, harder to wake them up, confused. So we would know, like, wow, what's going on with this patient? They're really having a hard time. Maybe their level is too high. So our side effects are mild gingival hyperplasia, which we've had a couple of times with some of our cardiovascular medications, mild sedation, and orthostatic hypotension. So they have to be careful about getting up. Multiple adverse effects, decreased heart rate, severe hypotension, hyperglycemia, especially if the patient is diabetic, and those skin reactions, toxic epidermal necrosis, and Stevens-Johnson syndrome. So it's a good time to remind yourself what is the difference between toxic epidermal necrosis and Stevens-Johnson syndrome. Can anyone explain the difference?
Well, necrosis is obviously like the skin death.
Right. So that's when the top layers of the skin and mucous membrane die and they can slough off. Stevens-Johnson syndrome is different though, and people have confused that in the past.
Stevens-Johnson is when the blisters come?
Yes, correct. So Stevens-Johnson usually starts with a feeling of an upper respiratory infection, like a sore throat, feeling kind of run down, and then the patient gets the blisters, like you guys are saying, and those blisters start across the chest, and eventually the blisters can sort of grow together. Where am I? Here we go. So we have to worry about those skin conditions. So anyone who has a rash should really report it to the provider to be sure and see if it's one of these skin conditions. And then taking or using alcohol can increase the patient's phenytoin levels. So they're more at risk to be toxic, to be greater than 20 if they drink alcohol. So they really shouldn't drink alcohol at all when using that medicine. Carbamazepine is the brand name for carbamazepine is Tegretol. It's again works just like phenytoin in that it blocks sodium from entering the cells. So it's harder to depolarize the cell, and we're trying to focus on the area of hyperactive nerve cells in the brain, but can affect other cells. This one has some other issues we have to worry about. Visual disturbance. Again, the Stevens-Johnson syndrome and toxic epidermal necrosis. The risk of those skin reactions is greater in a subpopulation of Asian ethnicity if they have this particular gene. So you have to be careful if someone who is of Asian descent is getting carbamazepine in case they have that genetic mutation. They might actually even be tested for the genetic mutation before they're started on it. Fluid retention, which increases the risk for people with heart failure. So they might not be able to use this medicine because we know that heart failure means the heart isn't pumping well enough and we're already having fluid in the heart. So we have to be careful. Excuse me. And then bone marrow suppression. So what are the cells that the bone marrow makes?
The white blood cells, the red blood cells, all that kind of stuff.
So, yep, white blood cells, red blood cells, and one other type of cell.
Platelet.
Yeah, platelets. So if the white blood cells are low, then the patient is at increased risk of what?
Infection.
Infection. So then we have to worry about infection. If the red blood cells are low, the patient is at risk of,
Anemia.
yes, ma'am, and
Yes,
then
ma'am. Yeah.
the platelets are low, they're at
Bleeding.
bleeding, yes. So for carbamazepine, it could suppress all those types of cells, but especially the white blood cells. So we have to worry about bone marrow suppression, we have to worry about heart failure, we have to worry about skin conditions. It's a pill, it's given with meals. If it's a sustained release, then it has to be taken whole, it can't be crushed, and no grapefruit juice. So there's another one with the no grapefruit juice for us. And then the last one in the traditional anti-epileptic drugs where we're blocking the influx of sodium to prevent depolarization is valproic acid or Depakote. This medication can be taken IV or PO. If it's taken PO, you can't give it with carbonated beverages because it can burn your mouth. If it is a capsule, this is one time where you can open it and sprinkle it on food. That's not very common. Usually you can't open capsules. Side effects of this medication are sedation, drowsiness, photosensitivity, which means they're more sensitive to the sun, like when we talked about with some of those antibiotics last class or last exam. Does anyone remember the antibiotics that increase photosensitivity?
Was doxycycline one?
Yep. There was one other. The other was sulfa, the sulfasalazole. So this is another one that does that. It can cause bone marrow suppression just like carbamazepine. And with this bone marrow suppression, the greatest risk is bleeding. It can damage the liver, causing liver toxicity, hepatitis, or pancreatitis. So a lot of different, some similar, some different adverse side effects of these medications. Clearly they all are not medicines that are easy to take. So there has been an increase, or there's been the development of non-traditional anti-epileptic drugs, which instead of manipulating sodium, would manipulate another electrolyte itself. Some of the ethosuximide and lamotrigine, which is Lamictal, those manipulate calcium. They are not gone into very much for ATI, so I won't either. You will notice that as you practice as a nurse that many of the medications that are used for epilepsy can also be used. Some of them can be used for severe migraine. Some of them can be used for bipolar disorder. A lot of bipolar medications are also epileptic drugs, especially more so now instead of using the traditional bipolar drug, which is lithium. So there are 2 activities that you should do before you go to lunch. I won't make you upload it, but I would like you to try to do it. And one is making this study sheet that I have for the for the traditional seizure medication, so that you got their adverse effects down and what their similarities are and what their differences is. And the other is a math quiz. And then you can go on your lunch break, because when we come back, we'll go over those things, and then we'll talk about behavioral health medications. So I won't make us suffer through a Dropbox, but I would like you to try to fill it out, or at least think about it as a way to study the seizure medications. So I'll open all that stuff because a lot of my stuff is shut down now. So do those two things, the math quiz 2, and we'll go over that when we come back at 1 o'clock. And then we'll go over the antidepressants and other behavioral health medicine. Let me just be sure everything is open for us. And I will see you then.